The unmet needs, they depend on where you are living. If a patient is living in the Western countries, I think that the very unmet needs is to get free of leukemia completely. For people living outside Western countries, in so-called developing countries, the real unmet needs is to the availability of the drugs that control chronic myeloid leukemia, because still too many people around the world, about 2 to 3 billion people, they have no access or a very limited access to the good drugs that are the tyrosine kinase inhibitors. But in Western countries, is to get free of leukemia. The choice of second-line treatment is important in about 30% of patients who fail imatinib. And the choice depends on the disease. So if there are mutations, we select the second-line TKI according to the type of mutations. For instance, if there is the T359 mutations, we select ponatinib. If there are P-loop mutations, we select dasatinib. If there are other mutations, we select nilotinib. But we select the second-line treatment also depending on the patients, the age of the patients, the comorbidities, because second-line TKIs like nilotinib, dasatinib, they're a bit more toxic than imatinib. But I must be honest, in about 50% of patients, we cannot make a choice, and it depends on the cost of the drug and on the availability of the drug. We can monitor using cytogenetics. We can monitor using PCR, so molecular methods. I think that today we use both cytogenetics and molecular monitoring, but in the next 5 years, we will use more and more molecular monitoring, quantitative PCR. And now we monitor PCR every 3 months. This is the current recommendations, but my opinion and my personal recommendation is to monitor every month during the first 6 months, because what happens during the first 6 months is really critical for the success of the treatment. So my recommendation is to monitor PCR every month for the first 6 months. There are no data. It is sufficient to answer this question. We know that we can stop TKI almost always, but the point is it useful? Is it dangerous? And we know that a patient must be treated with TKI for many years, at least 4 years. A patient must be in deep molecular response, that is so-called MR4 or MR4.5, in more than 1 year. So in a patient with more than 4 years of treatment with TKI and more than 1 year of deep molecular response, we can discuss with the patients and suggest the patients to take into consideration the discontinuation of the drug, which is important for the life of the patients, the quality of life of the patients, and also for the pocket of the patients. And this can be done also outside clinical studies. But there is a very important thing is to ensure that the patient is followed and monitored every month for at least 1 year. There are always emerging therapies. There are some important development in the area of tyrosine kinase inhibitors. So there are new tyrosine kinase inhibitors coming, for instance, which maybe are more effective. We do not know if there will be also more toxic. So there is space of improvement even in the area of tyrosine kinase inhibitors. And then there is another area that is developing also outside chronic myeloid leukemia, particularly for acute leukemia and for other disease, that it is cell therapy, T-cell and so on. But this is really a dream for the future of chronic myeloid leukemia. In the next 5 years, we will stay on tyrosine kinase inhibitors.